Hi, today we have with us Yahaira and Stephane-Ratway. They are speech therapists at Jackson Memorial Hospital in Florida. And I will let you guys introduce yourself a little bit to the audience.
Thank you, Jenny. Like you said, my name is Yahaira. I am a speech language pathologist at Jackson Memorial Hospital. I've been a licensed clinician for over 7 years. I work in acute care and mainly with patients status post lung transplantation.
And my name is Stephane-Ratway, Steph-Ratway for short. I am a speech language pathologist at Jackson Memorial Hospital and also at Kristen Lynn Rehab Center. I've been a clinician for 30 years plus. And I primarily work right now with the spinal cord injured population in the acute rehabilitation center.
These are really interesting populations that you work with. How did you decide to start a respiratory muscle training program, or why?
Well, mainly because of the overwhelming literature support that's out there on the benefits of RMT training for these patients. Particularly in my case, in the acute care, patient status post lung transplant, sometimes there are some complications post-operatively. And so these patients have a very difficult time liberating from the ventilator. They take weeks. It can take weeks. And so this was very, very important for us to add this to our toolbox so that we can help these patients liberate as quickly as possible from the ventilator. And move on to the next level of care. And of course, the dysphagia risk for this population is very high as well. And it's something that we want to manage early and as aggressively as possible. So that's another reason we incorporate RMT.
And then for my population, we know that with spinal cord injury, especially with the high tetraplegic patients, those who suffer injuries, in the high cervical areas, the number one threat to their lives really is respiratory, especially early on in the acute stage, and then also when they finally make it here on the acute rehab stage. So this is something that their respiratory health is something that we have always sort of felt that it was paramount to address. And respiratory muscle training, again, due to the overwhelming literature that supports actually the benefits for that population. That's one of the reasons why we incorporated that.
That's amazing.
Yeah.
You do
and
amazing
just if
work.
I can elaborate even a little bit more, so we make sure to incorporate RMT for our patients that are lung candidates, even at a prehab level. To make sure that we're maximizing their inspiratory and expiratory strength in preparation for lung transplantation. And then as soon as, we're post-op now, as soon as their sedation is weaned, we jump on board. If the patient is orally intubated for more than the operation, PT and OT will make sure to incorporate RMT as soon as sedation is weaned. And if the patient receives a tracheostomy, then I would get involved as early as possible to make sure that we're working on cough effectiveness, secretion management, and all the other amazing benefits of RMT.
That's amazing. So you work with the team. You guys have PTs, OTs, everybody working on it together?
Absolutely. Yeah, we do take a lot of pride in that. We've been able to build a multidisciplinary approach to RMT, and it's been very, very successful. So yeah, RMT is done by PTs, OTs, and speech.
Absolutely.
And that's my soapbox, interdisciplinary.
Yeah, absolutely. And we even continue that in the inpatient rehab facility, especially with length of stays in rehab being so significantly reduced. Right now, we fight for 4 weeks for our tetras. I mean, that's a very, very short time. And we typically get about 2 weeks or 14 to 17 days for our paraplegic patients. And so it's so important to actually have co-treatment sessions with physical therapy and occupational therapy. And when the patients are involved in any kind of physical activity that actually help with opening in the chest wall or expansion of the chest wall. I'm in there with my RMT device, and we're working together with that goal, that common goal.
That's amazing. I applaud you for sure for that. And the same way in my facility, I'm always preaching everybody work together. And what about in terms of any special considerations or challenges that you have come across working with these populations in regard to RMT? Could you share something about that?
Well, I guess I can share a little bit on the acute care side. Of course, these patients are really deconditioned, some more than others, particularly in the post-op phase. And so a lot of times we do have some barriers as far as, their respiratory status and how much support they're getting on the ventilator. A lot of these patients are even on ECMO for prolonged periods of time. But thankfully, our surgical team is very supportive of RMT. So very rarely, I don't think it's happened yet, to be honest with you, where we'll engage in the discussion of should we start RMT for this patient, and I've really never gotten a no. But it's something that I have to proceed with caution, because from a respiratory perspective, these patients sometimes are breathing well over 30 times per minute. Saturation on a good day is 89, 92%. But, we use our clinical judgment, and very rarely have we not been able to at least start something at a low threshold, low repetition. And we always are successful with no adverse events.
Amazing.
And then on the spinal cord injury acute rehab side, one of the things that the challenges are with the blood pressure. So the patients are coming in not having had many opportunities to be upright, and so we have a lot of challenges with orthostatic blood pressures or hypotension. So the minute we try to sit anybody up, they sort of tank. And so using binders and other aids to help with stabilizing their blood pressure, and the physicians here also use medications to try and stabilize the blood. So early on, especially the first couple of days, the first few days of their rehab stay, that's a challenge. But the great thing about RMT is that there's no steadfast, protocol, right? So that we can actually adjust positioning, we can adjust the load when working with an EMT, or an IMT device. So we've been able to work through those challenges. That's usually where we begin. Some of our patients in the spinal cord injury floor are also trached, and so sometimes again they're coming in completely deconditioned. So as long as we keep in mind some of the contraindications, right? We're okay. A lot of our patients, sorry, I just wanted to say that a lot of our patients, they have the SCI because of trauma. So of course, there's a recent history of a pneumothorax, for example. We of course back off and wait, and that may just delay the process a few weeks. And so in the outpatient, the physical therapist can sort of take on that goal.
I thought it was so interesting and important that use of clinical judgment, and that there is not a set protocol, especially with this patient population, where you do have to adapt, right? Like you do have to lower the pressures, or you do have to lower the reps and kind of just go with them and see what they do. But it does help. Like whatever they can do is still some work for them.
Absolutely.
Yeah.
Absolutely. It's like somebody going to the gym and doing a 20-minute workout versus, an hour workout. It just depends on your condition and what you can tolerate. That's how I see it.
That's the perfect analogy.
Yeah.
Yeah,
Something
exactly. That's
is
what I
better than
tell
nothing. Yeah.
Correct. And then you work up, right? You build up.
Absolutely.
Because you start
Yeah,
somewhere and then you build that strength. Yeah. And would you share a success story with us?
Well, I had the opportunity to present one of my success stories at the 2022 ASCIP conference in Kansas City this year, which was really an amazing experience. And ASCIP, for those of you who don't know, it's the Academy of Spinal Cord Injury Professionals, and they put on a conference like ASHA every year. I had an opportunity to co-present with a physical therapist one of our case studies that is now launched a study that we're going through right now, that's going through the IRB process right now. And our focus was using respiratory muscle training in conjunction with functional electrical stimulation to help with an unaided cough of a patient with spinal cord injury. And looking at the different values that we looked at, obviously the MIP and MEP were values that we looked at, but we also looked at forced expiratory volume and then forced cough as well, volume, to see if we saw a difference. And we were able to showcase, I think we trained, the case study that we presented was a T4 paraplegic woman, elderly woman. She was in her late 60s and had a very weak cough. And after 2 weeks of training, we showed a significant improvement with her cough. Not only we saw the values, so we had the objective measures, but perceptively she also noted that her cough was better. And incidentally, the other thing that she noted that she was able to sneeze out loud, which she was not able to. And then she also told us that her laugh was actually closer to her laugh at baseline prior to her accident. So it was pretty interesting, pretty cool.
That's a really beautiful thing.
Yeah, absolutely.
Yeah.
Because we were not only affecting the respiratory health, but really, everything, right? Their quality of life. I mean, she was able to laugh, and she said,
like
"Oh my
giving
God,
back to her."
Yeah,
so
and we
important.
gave that back to her. And I didn't, we don't even think about these things, but yeah, it's pretty cool.
We take it for granted, for sure.
Absolutely. Yeah.
Thank you. I mean, thank you for sharing that. That's incredible work. Congratulations on that.
Thank you. Yeah.
Yeah, that was so beautiful. I wish I would have gone first now, because now I have to follow you. Sorry.
I'm sure it's going to be good too.
It will be. Lung transplant, hey.
Yeah, yeah. So I actually recently had a patient that was probably one of the sickest patients I've ever had. Max support on the ventilator, also on ECMO, very, very, very stiff, non-compliant lungs. I remember actually it was the first time I've ever seen a chest x-ray with total whiteout. Never seen that before. And, I got a consult for the patient, and the numbers were not good. Like saturation at best was like in the 70s, respiratory rate really high. And so I knew I had to get involved. I knew it wasn't the right time when I first got the consult, but I watched him. And as he tolerated being awake more, as he tolerated activity more, I kept going back to the PT and OTs, like, how is the patient doing? How's he tolerating being awake and off of sedation? And as soon as I saw a window and saturation at this point was already a little bit better, I got involved. I got the team's blessing, and I got involved, and we started right away with RMT. And I remember I just did like one rep at first. I was like, let me just see what's gonna happen. I had RT with me in this case. And we did okay. And then slowly but surely, we started building on our reps. He tolerated it beautifully. We started with inline valve. I remember that was a really special moment too, when he spoke to his wife. At first, his speech was very low, a reflection of his poor respiratory status, of course. And within a week, he was saying sentences that were intelligible. And it was really, really, really cool to see. And it was really, really special. We liberated from the ventilator at some point. That came first. Then we weaned off of ECMO. And this patient, unfortunately, wasn't a candidate for lung transplantation. So we knew that we had to be as aggressive as possible to try to regain as much lung function as we could. And this was such a success story. It took it took all of us, right? All the therapists, and it took a lot of medical intervention as well. But eventually the patient weaned from the ventilator, from ECMO, was able to regain swallow function as well, was able to advance into regular solids at some point. And he went home on nasal cannula, if you can believe it. Wow. And I really don't think we would have gotten there without being aggressive with RMT. Luckily, we also had really strong family support that would carry over the recommended protocol for RMT. And I think that made a huge difference.
That's pretty cool.
You made a huge difference. That's incredible. Both of you, those are great stories. Thank you so much for sharing them. And thank you so much for taking the time to speak with us.
Yeah, my pleasure. Anytime.